Good morning or good afternoon as the case may be, and thank you for joining us. I'm Kathleen Morris, and I'll be your moderator for today's session. I'm the VP Research and Analysis at CIHI, and I'm very proud to be a member of the CRDCN Board of Directors. CRDCN and Statistics Canada welcome this opportunity to convene colleagues during this extraordinary time in our country's history. Bon matin ou bon après-midi à vous tous, et merci de votre participation aujourd'hui. Je m'appelle Kathleen Morris et je travaille à l'Institut canadien d'information sur la santé. J'ai le privilège d'être un membre du conseil d'administration de RCCDR et je suis votre modérateur aujourd'hui. There are more than 150 of us online today, from universities, from governments, and from the not-for-profit sector. Exactly what we hoped for, since this series is really about connecting colleagues and ideas for the common good. It's also about leveraging our collective ingenuity and bridging gaps and overcoming limitations together by focusing on the art of the possible. Nous sommes plus de 150 participants aujourd'hui. Les chercheurs, les spécialistes des données et des politiques publiques. Je suis certaine qu'ensemble, nous pourrons répondre aux enjeux essentiels. J'espère que cet événement vous encouragera à continuer à porter main forte aux efforts d'analyse et d'engagement reliés à la COVID-19. Bien que ce webinaire se déroule en anglais, un résumé bilingue sera disponible dans les semaines à venir. Vous êtes aussi invité à poser vos questions dans la boîte de questions dans la langue officielle de votre choix. Before we start, some birthday wishes and some thank yous. CRDCN is celebrating its 20th anniversary this year and would like to thank CFI, CIHR, SSHRC, Statistics Canada, university partners, as well as the provincial government and private sector partners for their ongoing support. We are delighted today to welcome our speakers to speak about population health and health services. David Green, Rhonda Kropp, Julie Bernier, and Tracy Afifi. Each panelist will have 5 minutes to reflect on COVID-19 and how it informs research questions, the data that can help address those questions, and how we might cross geographies, disciplines, and sectors to inform Canada's efforts. After we've heard from all 4 panelists, we'll ask them to address your questions, both questions that you've shared in advance when you registered, and additional questions that come up today. So I really encourage you to please submit your questions in the Q&A box during each of the presentations. We'll get to as many of the questions as we can, but even if we don't get to yours, they still will provide valuable insight that can inform CRDCN's and our panelists' efforts going forward. So without further ado, let me invite David Green, Professor of Economics at UBC, to be our first presenter. David will share some of his experience in accessing COVID research funding to address topics that bridge economic and health issues, and to share some of his creativity in accessing data. Over to you, David.
Thanks very much, Kathleen. Thanks very much for the opportunity to present. I really appreciate it. I'm just going to bring up the slides that I think were sent around. So what I'm going to do is actually tell you about a project, or actually a set of projects that we have going in response to the COVID-19 crisis. So why is that not working? Oh, there we go. Actually, right at the end of March, Reka Gustafson, who's the head of the BC Centre for Disease Control, contacted us being the Vancouver School of Economics, and asked for input on the sort of economic impacts and the interaction of the economy and the virus. Reka was way out in front of most people in that everything was just focused on the virus at that point. But what we did was a few things. One was we formed ourselves into a set of teams, and you can see the set of teams here. We're looking into sort of the current state of the economy. A lot of that actually morphed into a project that is estimating impacts of policies. And then another big one was macro models of the economy and the virus. And we're working with some of the math modelers on that and the inequality and poverty implications. But the one I'm going to talk to you about today is an attempt to sort of bring together information on economic outcomes by industry and occupation with measures of the riskiness of the occupation. What I mean by riskiness here is whether when people are at work at these occupations, they're likely to spread the virus. And so it's a bit of an attempt to understand the trade-offs that are there when you either open up or if a second wave comes, if we have to shut things down. What we did immediately after that was contact Statistics Canada. And Statistics Canada has been unbelievable. The response was really fast. It's been very strong. And honestly, nothing that you're going to see would be possible without the response that we've had. Essentially, and a lot of people online can appreciate this, what we needed access to data that was not the public use data. We needed data at a finer level of aggregation in terms of occupations and industries than we could get in the public use. We essentially needed to get into the RDCs. And what Statistics Canada did was essentially set up a project where we could do that. We could access what is essentially usually RDC data. They required at the outset a letter from the BC CDC to say, yes, this really is work that is being used directly for policy. And we got that easily because the BC CDC were the ones who asked us to get going on this in the first place. And then we set up an arrangement that took a little while to get going, not very long. By a little while here, I'm really actually talking about days, although at that point, everything felt really, really urgent. And we ended up working with Cindy Cook and Mark Saint-Denis, and essentially a part of Statistics Canada that was already moving towards thinking about how to do remote access to RDCs, and they essentially just moved that up at light speed. And so what happened was we have a set of data sets that are in a walled off part of the Statistics Canada server that we can access. We access those through, I think we have like 6 secure laptops. And then we had essentially all the researchers were sworn in under the Stats Act, but of course, almost all of them, I think pretty much everybody was an RDC researcher in the first place, so we already had that access. And then we were signed on this specific project, just like you would do with RDC projects. There was a few things to work out. So for example, the secure laptops were in the hands of RAs, or are in the hands of the RAs for the most part, so that we can sort of centralize the access. But we needed to be able to do the equivalent of sitting down next to the RAs and the RDCs, but we couldn't do that. So we were given the right to talk about what was on their screens before they were vetted, as long as, again, only the people who are sworn in under the Act and who are part of this project. Then the vetting of results follow RDC protocols, and the getting everything out has been very efficient, really well done. The other stipulation I should tell you about is this was really from the outset. They were like, this is for policy support. It's not for your regular research. And so the agreement was, we're not publishing anything off of this. We have the right to go back in and access the data after the RDCs open, like any other RDC researcher, and essentially take some of the code that we've developed and use it at that point, and then we can vet things out and put them out for publication, but nothing comes straight out of this, except for inputs to the policy process. And once again, let me say that without what Statistics Canada did, nothing would have happened. We've not only at this point are advising the BC CDC, the tool I'm about to show you is being used throughout the BC government, and more recently, LMIC has given us the resources and support to create this for every province. So let me then just jump in. Essentially, we think of this as a risk versus reward measure. And on the risk side, we have a set of characteristics of either the jobs or the workers that, in conversation with the BC CDC and the ENSPQ, we learned from the frontline people what it is that they were concerned with. And so then we went and tried to get measures of those. And the first set of measures come from a linking of the ONET. And the ONET is a database of job characteristics. It's a US database. We linked that to the LFS and to the census through 4-digit occupation, at the 4-digit occupation level. And I should say that the linkage there all had to do with crosswalking from their version, the ONET's version of occupations, to the one that's in all of Statistics Canada data. And we used a crosswalk that Mark Fournette and Statistics Canada developed, which we were very happy to find. We all have a lot of respect for Mark, so we knew as soon as we saw that we were in good hands, and we really adjusted it almost not at all. The second set of characteristics are ones that actually come from the census. So for example, what proportion of workers in an occupation commute to work on public transit, what proportion live with healthcare workers, and so on. And you can see the set of measures that we have here. On the economic impact side, we look at either the size of the industry, the employment change, or a measure of centrality that comes from input-output tables. So it's a sort of a notion of if this is an industry, the output of which is used in a lot of other industries, then we're going to call that central. And we're essentially looking for industries that are low on risk but high in centrality. Those are the ones you'd like to open. As I said, there's other measures that are coming out of the census, and we're also using measures that come out of the CCHS. We're just starting on that. These are sort of risk factors, like what proportion of people in an occupation smoke or have diabetes, et cetera. Just as an example, so this is one of the ones that came up that was suggested to us by the health authorities. And when we went to look at it, there were some sort of interesting results. So what proportion of workers in a given occupation live with healthcare workers? Not surprisingly, a high proportion of people who are themselves working in health occupations live with healthcare workers. One of the interesting ones that came up is, for reasons we have no idea about, construction and building trades workers have a high proportion of living with healthcare workers. So basically on the same order of magnitude as registered nurses, and double or more what you see, for example, as elementary school teachers. We don't know why this is true, but it does mean that you think about construction and it being open, now you understand, okay, these are people moving around amongst job sites, and when they go home, they're disproportionately likely to be with a healthcare worker, and that's important. Who lives with somebody 60 years or older, which is a risk group? A very high group for that is hairstylists and barbers, which strangely in our mind is one of the first places to be open. This is just saying the same thing I said before. We basically link to the ONET data, and these are the main characteristics that we've drawn out of the ONET. Whether you are exposed to disease at work, physical proximity, that is, how close are you in general to other people at work, et cetera. I'm not going to do this part just for speed. So let me say that this is a part of a big team on our side, but also there's a Quebec version of this, and we have weekly meetings with the Quebec team. They also have access in the same terms to the Statistics Canada data. And so we're sort of jointly developing this with them. So let me just quickly here show you what this tool looks like that we've developed. I'm just going to show you the static version just so that it's quicker, but all of this is interactive. What you have here is what we call the bubble chart, and the bubble chart has these are essentially 2-digit industries that in this case are arranged by their employment size in 2019. This is British Columbia at this point. And they range from, on the right side, the biggest sector is actually the healthcare sector. And then we get down to ones, construction is sort of in here, and we get down to smaller ones at the other end, sort of like finance, et cetera, is down here. The bubbles in each column are occupations, large occupations groups within the industries, and the size of the bubble is the relative size of that occupation within that industry. And then if you click on any one of these bubbles, you get a piece of information, you get a box that gives you information on the size, the value of the risk index that I'll tell you about in 1 second, and other characteristics.
Okay, David, I'm just going to give you a 2-minute warning, a little bit less. Thanks.
I'm almost done. Thanks, Catherine. When you click on that, the other thing that happens is it takes you down to an interactive, a dynamic table down below. The dynamic table in this case, so I happened to click on the sort of other services sector, and I clicked on the top bubble in that. So that was on the y-axis here is our index of riskiness. The index is made with those 9 series I told you before. We actually get it with factor analysis, but you can just think of averaging them after standardization, and that is effectively what this is, pretty close. So when we go down here, now what we get is we start getting down to the 4-digit occupation levels here. These are all sort of within this sector of other services. And then we give you the value of the index. The value of the index is color coded to show you the deeper the red, the riskier it is. You can use the buttons up here and rank everything, rearrange the table. So for example, you could rank these by riskiness, which I think is what I've done here. So the top category here is hairstylists and barbers. So they are in fact the riskiest occupation that we have outside of the health sector. Up here on the tool are a set of other tabs, and you can, when you click on those, you get the whole list of values of those scores I showed you before, sort of like the proximity score, the number of contacts score, those are in here, the job description. The economic indicators, that's size, job loss, centrality, and the household values, that shows you things like, do you live with a healthcare worker? We have breakdowns by age, by education, by gender, by whether you live in a low, the proportion of workers in an occupation who live in a low income household, et cetera. So this is essentially a big compendium of data. And the idea about this is less to tell people you need to put up a shield here or something like that, than to give a consistent way for people to think about the riskiness and the advantages of opening or closing different sectors, so as a basis for having policy discussions at a sort of level of that kind of level. Which sectors, which occupations are we most worried about? Okay, that's it for me. Thanks, Kathleen.
Okay, thank you very much, David. And I'm just going to encourage people to do their very best to try and stick to their 5 minutes. I'm just going to do a quick check to see if we have Rhonda Kropp on the line.
Oh,
and there she is. I can see
I am here. I just had to unmute. Can you hear me okay?
We can hear you fine, and I'll just introduce you, Rhonda. Rhonda is the Assistant Vice President at the Public Health Agency in the Infectious Disease Prevention and Control Branch, and she's here to speak to us today about some of the categories of data gaps that she's seeing at the agency. Over to you, Rhonda.
Thank you so much. Very happy to be talking to you all today, and for some of you that may have been on the CIHR workshop a couple days ago, this is going to sound a bit like a replay, and I apologize for that. So in the context of COVID, we have a couple of areas that we've been focusing on. The first is the data set that we currently receive, which is data that flows from the provinces and territories on individual cases. And also, in addition to that, other data gaps that we have that will never be achieved through routine surveillance that we need to fill. I'm going to talk a little bit about both of those areas. So in the first case, for the COVID data set that we currently receive, there's a couple issues that we're currently dealing with, and this isn't new to COVID. This is just the way public health surveillance works. That's always been a challenge. One is the timeliness in which the data is flowing. Number two would be the granularity of the data that we're receiving. So in order for us to look at things like impact by race, ethnicity, for example, we don't currently get that information on the case report forms. So it's very difficult for us to answer some of the key questions that we're getting asked nationally about who the impacted groups are. The third is incompleteness, and all of us who work in data know that anytime we're collecting information, the completeness of that data can be really a challenge in terms of our ability to draw conclusions from it. So we're working on that as well. The fourth issue has to do with integration of the data. So we've got data that flows from the epidemiology side of things, the lab side of things, the clinical side of things. And in an ideal world, we would be able to link those sets or have them flow into one common portal. So currently we're challenged by having data sitting in different places. That makes it a little bit difficult for us to, in any way that is easy, pull stuff together and create that national picture. And finally, as is the case with research data as well, getting the information out so that it is accessible and able to be used for multiple purposes, with all the caveats, particularly in the case of surveillance data, of the limitations of that data. When we collect surveillance data, it's not collected with an eye towards doing research, but clearly it is an important contribution to the data landscape that we could be capitalizing on more within Canada. So we're working with our provincial and territorial colleagues to try to address some of those issues. But in addition to those, we have a number of key data gaps, which we are hoping to be able to fill, in part with our colleagues like Kathleen and others with CRI and StatsCan and other partners, to try to fill gaps that will never be filled and really can't be filled through routine surveillance. Some of those things include high on our list, so the race ethnicity piece and the burden by different populations. Second would be healthcare workers. Lots of interest in trying to understand the burden that COVID has had on healthcare workers, and not just healthcare workers as a broad category, but really drilling down into the different categories of healthcare workers, if you will, so that if we're putting some interventions or programs in place, that they would be able to be targeted appropriately. The third one has to do with unintended consequences, which is a massive bucket. So under unintended consequences, we're talking about the consequences of the public health measures that have been put in place. And some of those are positive and some of them are negative. And there's been quite a bit of work already started on that front, but we have a long list of unintended consequences that we're particularly interested in, including family violence, substance use, sexually transmitted infections, changes in perceptions regarding and action regarding vaccination, a number of these pieces, and to understand some of those unintended consequences by particular populations, risk populations, including things like sociodemographics, indigenous populations, et cetera, et cetera. So that's a really, really big bucket of information that we're trying to fill. And then the final one I would flag is trying to ensure that we really understand the nature of the outbreaks that Canada is continuing to see. We do outbreak investigations, and the provinces and territories do a great job at bringing all of their wisdom to bear to deal with outbreaks when they occur. But the outbreaks also serve as an opportunity to potentially do some research on and understand what is driving those outbreaks, what can be done differently from public health practice. So we have been looking at that as well. So I would just summarize to say that across these two areas, we've got this core data that we know we need to try to improve in the short term as quickly as we can. But then we also have these other data gaps that we need to find solutions to try to fill those gaps. And the gaps that I've mentioned, I'm absolutely certain are in a large part common to many of our colleagues who have similar concerns regarding COVID data. So I think I'll stop there, Kathleen. I'm hoping that I might have saved a little bit of time.
Absolutely bang on, Rhonda. You were perfect.
Okay.
Thank you. And that was great. And I'm going to turn now to my colleague, Julie Bernier, the Director of Health Analysis Division at Stats Canada. And Julie will share with us some of the new data analysis and tools that Statistics Canada has been working on, and how down the road, some of that information and resources might be available to CRDCN researchers. Over to you, Julie.
Thank you. So at the beginning of the crisis, Stat Canada get organized with having a committee like across the bureau working on COVID. It's really a cross-cutting topic for us. Like it's a kind of a circle in order to avoid propagation. We put measure in place, the Canadian, and those measures will have an impact on health, and the impact on your health has impact on your ability to go back to work. And so it will be something really difficult to disentangle. So it's the perfect example of horizontal or cross topic that Statistics Canada is well positioned to think about and collect information on. So we created at the beginning 4 main groups that we're looking at data gap, how to share data, information that we could collect or that we already collect on a regular basis. So the first group is a group that start working on producing a weekly dashboard on a lot of economic factors that we tend to measure monthly, quarterly, but then all of a sudden we're using method to do what we call nowcasting, and we provide a week-to-week curve with how productivity is going, how labor force going, how certain sector of the economy are going, because there are sectors that are doing very well during the crisis. So that's one of the tasks that we're doing. The second task is we were already ready to launch a geo-analytic system to look at information that Stat can produce in the way that is as granular as possible. So we take the opportunity to launch that tool, and as we're going and collecting information and partnering with other federal departments, we're adding more and more data into that tool that's available online, that people can go consult, look at map. A lot of health variable are there. Actually, anything we're working on these days go directly through the geo tool. The third group is a group that was put together to collect information on the social impact. Considering the overlapping of all the different dimensions, we decided to collect data. We create two collection tools. One is crowdsourcing. So we had developed a crowdsourcing application 2 years ago to pulse Canadian on their habit toward cannabis consumption price frequency in preparation for legislation. So we reopened that tool with questions that are rotating on a bi-weekly, I think, pace. So we had certain of them that are already done. We did one on direct impact. So did people stop working, work from home, change their hygiene habit? There were one on student, asking them what's the impact for them or having to finish their school year at home and things like that. We've done that on, at the moment, we're collecting information on mental health, and there are at least 3 other ones that are in the room. At the same time, those are crowdsourcing. So sometimes the first one, really, really big take on, over 300,000 respondents, but depending on the topic, sometimes it's lower, sometimes it's higher, and it tends to attract a certain share of the population. Like for some reason, the first one had a big take on by women more than men. And the other tool that we developed is we were already in the process of trying to develop panel that we extract from some of our regular surveys. So we use LFS to create panels. And up to now, we've run 2 surveys using those panels. The first one was also in impact. It was pretty similar to the crowdsourcing because we wanted to use that also to check what was the quality of the crowdsourcing. The second one that's online at the moment is on food security, and we will keep doing other ones. So those are data that as soon as the data are processed, there's a daily announcement that the data are available. The data are available on a PUMF, like a public use micro file format, so that people can download it from the website. And the micro data later on, when we're back to normal, will all be available in RDC. So a lot of information. And finally, the last bucket is a bucket that was working on modeling. So this is maybe less close to the kind of work that is done in RDC, but we're supporting, helping FACT with their epidemiological model. We're helping Health Canada with modeling the need for protective equipment and all sorts of things that you can imagine would need to be modeled or think through a couple of weeks or a couple of months in advance. So we start with those 4. Since the beginning, we have grown into multitude of activity. We're helping FACT with the case data that they're collecting on a regular basis are now put on our website too for consultation, tab, cross tab, by province, by certain characteristic. So we're used as a dissemination tool. And at the request of a lot of researchers who were telling us that it was critical to compare with the death rate on a typical year. And okay, people who work in RDC know that we usually produce death record 8 to 10 months after the end of a certain calendar year. So we've asked the province if they could give us data that will be considered provisional data, like not the final one, so that we could put data table in the website, and we start doing it early this week. So those are the data and information that we're working on. And just also, we have a COVID-19 banner on our website, and from that banner, you can access data, content, map, the geocode system, as well as a new publication that we've launched. That's a bunch of little 2-pager to tease people on what are the data we collect on crowdsourcing or on the panel.
Excellent. Merci, Julie. That was great. Last but certainly not least, I'd like to introduce Tracy Afifi. She's a professor of community health sciences at the University of Manitoba, and she's going to share her thoughts about how researchers can cope with some of the challenges of COVID, including making some quick shifts in their work and balancing COVID research with business as usual. Over to you, Tracy.
Hi, thank you so much. So thanks for having me to talk on this panel today. I've already learned so much listening to the other panelists. But I'm an epidemiologist and I'm a population health researcher. My expertise is child maltreatment, mental health, resilience, prevention. At least that's what I would have said 2 months ago. And I'm still those things, but now I'm also a COVID-19 researcher. So I'm going to touch on some of those challenges for research, being a supervisor, and having to quickly pivot during these times. So I work with large population databases at the RDC, but I also collect my own survey data, and I link those data to administrative data housed at the Manitoba Centre for Health Policy. So until March, it was business as usual for myself and my students, and we were analyzing data that we had collected. We were analyzing data at the RDC. We have been planning for additional wave data collection for the fall. And then all of a sudden, the world began to change. And so with it, health was changing for individuals and health service use was changing. So I needed to understand what that meant for me as a researcher and whether or not I was going to also change with it. So what were some of the challenges? The data, my own data was housed at my lab at the University of Manitoba, which I no longer had access to. Other data were housed at the RDC, which was now closed. I have had many research assistants who I was paying off of grants, yet we were running out of tasks to do and falling behind on our progress on those grants. I had students who were using RDC data for their thesis work, which no longer had access to that data. And I'm also a mother who is with 2 school-age children who need to be homeschooled, but that of course is a whole different webinar. So many challenges, and so I had to come up with a plan on how to minimize some time loss and still remain productive during this shutdown. So with some permissions, I was able to access our own survey data remotely. So there are ways around that in certain cases, and I feel like there's sort of different rules that can apply during these times. So that's something that we were able to do. Also, I wouldn't have predicted 6 months ago that I was going to be obviously a COVID-19 researcher. So, but that's sort of the life of a researcher. I believe you have to kind of go where the science leads you and to where the questions are that need to be answered. So that's sort of what we've been doing. So as an aside, of course, the RDCs still remain closed and hopefully they'll be slowly opening in the near future. But we've been able to still move forward with some of those RDC projects. We had some data vetted, so of course we can still finish writing those papers. But there's many projects that we didn't have data vetted for and the analysis were not complete. So we've been working on updating lit searches and writing sections of those papers, even making the tables to await data and to write some of the discussion sections in general terms. So we're sort of out of sequence, but it's possible to do that and we can sort of things moving forward. I think it's also important for researchers to have the ability to pivot. This is especially the case during COVID-19, but might also be the case for in generally speaking. Sometimes you have to go where funding is. And I know a lot of people have developed whole areas of research that they wouldn't have expected, but that's what they've done because that's where the funding opportunities were. So with COVID-19, it's interesting to me how it's sort of made research programs that were typically not related. Now there's connections to different research programs. So it creates this interdisciplinary research opportunities that might not have normally existed. So in order to be flexible, it is difficult to pivot in the short term, but I believe that has long-term gains for knowledge translation and policy development and also for new collaborations. So my goals have been to be nimble during this COVID-19 time, to expand my collaborations in efficient ways. So I think that it also has to make sense to individuals' original program of research. You don't want to just start doing a whole area of research that's not related to what your expertise is. But at this time, I think many researchers are going to have the same questions. And I think it's better to join together with a greater effort with each of us doing things together instead of all of us trying to do similar things on a smaller scale without talking to each other. So I think webinars like this are good opportunities to sort of make those connections and think of those things and how we can do that. I think as a researcher, it's also important that we don't lose sight of your original area of research. So again, it's not about starting a whole new area, but how does COVID-19 relate to your program of research? For me, it's how does COVID-19 impact family conflict, child maltreatment, intimate partner violence, parenting, mental health, well-being, resilience, and resources that children and families need. So it's how to integrate that. And so what I think is really important is we've known for years that we can't work in silos, and that team science has become very important, and so has interdisciplinary research. But one thing that hasn't followed that in the same way is that our data sometimes are still in silos. So for me, the most important thing is keeping kids safe. So that's family violence and child maltreatment. You can't have health, education, economic stability, any of those things without children being safe and families being safe. So what we need to do now, I think, is to work together, but also bring the data together. And that's one thing that I think is still challenging during these times.
Tracy, that's a great note, I think, to leave us on. That was a fabulous presentation. And I think a huge thank you to all of the panelists today about packing a lot of great information into a very tiny window. So I appreciate your efforts. I'm going to encourage everyone, if you haven't had a chance to already, to make sure that you get your questions in using the chat box. And we'll try and get to as many of those as possible. And maybe we'll start right away. So Julie, I'm going to get to you up first. The question is around when will, we've talked about crowdsourcing in your presentation and people were very keen on that, but they want to know when will nationally representative data on the demographics and other characteristics of COVID-19 cases be available, and will this be linked to other data sets that would be in the RDC? Building on Tracy's point about the connectedness of things. And then as a follow-on to that is, will any of this health data be available at the census district, CSD or CT geographies?
Okay. Yeah, so regarding the characteristic, for now, what you have to understand is the crowdsourcing, the panel, all that information, and even some of the dashboard that we're presenting at the moment to talk about hotspot, depending on how many elderly there are in certain geographic region or people with comorbid condition and so on and so forth. This is all produced using StatCan data that will be available in RDC, and as any of our other data set that's available in RDC, that will be open to recording cage based on the typical proposal and demonstrating the good of doing it. So it will be possible to add a lot of contextual information to those data. The COVID case, as they state right now, are collected by FAC, and maybe it's for a talk with Rhonda. So those data are collected by FAC. We receive it, we process them, we put them outside because we have the mechanism, we have the system, we have the tool, we have a daily, so we can announce every week that we have new count available. Those are not StatCan data. They are not collected under our authority. So as of now, like there's no, like, it's not up to me to say where those data will go. They are not StatCan data. In the other end, at some point in 1 year or in 8 months, we will have on our vital stat data a lot of people that will be classified as having died by from COVID, as well as in the hospitalization file that we receive from CAI. So in maybe a midterm, I'm not talking about the short term because CAI hospitalization data takes time to collect from the hospital. Maybe it's not the highest priority now to college all information on everybody in the hospital. Same thing for the death record, but there will be a point where COVID-19 is a code that exists in all StatCan data holding, and it will be available. And once it's in our regular holding, it's always possible to link with the census for characteristic and the other activity that researchers are used to do. I think there were a second question in your question.
It's just around the granularity of the data. Will it be available at, for example, Census Tract?
Okay, up to now, what we're putting in our geocoding analysis system, I think the acronym is Canadian Geometric system, anyway. The geographic system depend on the variable. A lot of variable we extract from CCHS or the census, they're available at very low census geography. A lot of the information that we put there, if it's around the number of LTC, long-term care facility, the number of bed on high unit care and stuff like that, we put it at the health region because that's where it was, at the level where it was needed and expected to be delivered. But I went on the geographic tool this morning and was able to flip from health region to census depending on what variable I was looking at. And I know that at the moment we're really, really busy creating a lot of data. And by the way, in March, only less than 10% of the StatCan employee were working on StatCan network because it was a problem for us to all work from home at some point. So a lot of the activity were concentrated around COVID, but a lot of demand from multiple departments. So we created thousands of data tables. So at the moment, we go to the granularity that we can go without violating any rules. In the future, it was always in our mind when we created that tool that we will use more advanced techniques such as a small area estimation, interpolation, to bring the data, all the data at a lower census geography. But at the moment, a lot of the health information is at the health region.
Okay, Judy, thank you for that. David and Tracy, I'll point to you for the next question because you both work closely with policymakers. And have you seen any sign that COVID is changing the way that governments and other policymakers are integrating research into their policy? And if yes, tell us a little bit more about how that's working. Tracy, do you want to start?
Sure. So I think that the answer is yes to that, but it's also, we're sort of at the very front end of it. I think that one thing that I've seen is connections with people that maybe normally not have been connected to. I think what COVID-19 has shown us is that it has an impact on health, has an impact on resilience and well-being, has an impact on food security, has an impact on education, on the economy, and we can't really work in isolation in terms of policies because they're related. And so I feel like I've had connections with people that I normally wouldn't have had connections to during this time because we need to sort of bring all of that together in order to make policies that actually work for Canadians.
Great. David, how about you?
Yeah, I agree with everything Tracy said. Our experience, I think one of the things, kind of right back to the heart of the question, my sense is that in all the jurisdictions across Canada, there has been a strong emphasis on working from evidence, right? And that's, you can see that in who talks in public. A lot of times in BC, it's the public health officer more than the politicians. So there's been a lot of emphasis on doing that. And so I feel like there has been considerable interest in bringing research to get involved. At the same time, this is a crisis and people are making things up on the fly. You know, whole big sectors are changing all at once. Whole parts of the government are having to wheel on a dime and try to do different things. And so we've found a little bit of difficulty at times figuring out exactly who to get information to. And then when we get there, they're like, oh, we've been looking for this for a few weeks or something like that. But there's a big appetite for it. It's still, I think, in some sense, a work in progress, figuring out how to integrate it fully.
Yeah, no, it's a tricky one, but I think, you know, both of your answers really, I think, augur so well for the RDCs once they're fully up and running again, because they do have that breadth of data and the ability to work with connected data, which is so important in this environment. So that's a very broad question. Then I'll move to a much more specific one that's come in, and this one is around maybe, I don't know if Rhonda or Tracy might want to take this. It's looking for help identifying any policy relevant research questions that are related to nutrition or diets. So, you know, we've talked about COVID affecting so many different aspects. Anything that comes to mind in terms of nutrition or diets to help this question asker?
I can go. Kathleen, if that's okay?
Perfect, Rhonda.
Awesome. So when I mentioned earlier that there's a lot of interest in looking at unintended consequences, certainly food security, diet, those are all under that umbrella. So from a policy relevance perspective, we would be very interested in understanding how the public health measures related to COVID have either positively or negatively influenced people's nutritional habits and even their purchasing patterns when it comes to particular types of food. So those would be policy relevant questions on the food front that would be of particular interest to the Public Health Agency.
Excellent. Thanks, Rhonda. And Tracy, any thoughts from you?
Yeah, I don't really have much to add to that. But when I think of nutrition and diet, I also, as mentioned, think of food security, which then, of course, is related to so many other things. So again, everything seems to be connected here.
Perfect. Okay, well, thank you for those. Martin, can I check in with you just to see what you're seeing coming in terms of the live chat?
Thanks, Kathleen. There are indeed some questions coming in, and thank you for those who are contributing. One that I think goes in the first instance probably in Rhonda's direction, although Julie might want to pick up on it as well, is what role can and should be played by national or provincial non-profits in providing access to information on vulnerable populations through crowdsourcing surveys or otherwise, recognizing that these organizations are on the ground, they have their finger on the pulse, and how are they being engaged?
Yeah, that's a great question, and it's one that we are thinking through currently, and maybe I'll start and then I'll pass to you, Julie, because we're working quite closely with StatsCan and other colleagues on this front. So certainly, as I mentioned, the core data set that we get for surveillance purposes is quite limited. And so some of that really important information about various populations that would allow us to disaggregate that information, it just isn't there. So for us to be able to figure that out, we need to use other sources of information, other sources of data, and colleagues that are working on the ground and have their finger on the pulse of those particular populations are an absolutely vital source of that information. There's no question about it. This includes, for example, Indigenous populations who we're working with through our partners at Indigenous Services Canada. We do get information on Indigenous identification on the case reports, but it's very poorly completed. So we are working with our colleagues at Indigenous Services Canada and with different Indigenous groups to try to, for that particular community, improve access to data for those communities to do analysis for their communities. For other vulnerable populations, we're working with partners such as CIHI and with StatsCan, with others, to figure out how best to reach into these different groups that may have that intelligence that we need. But we're also really interested in understanding, even from a qualitative perspective, what some of the experiences have been. So for example, when we're developing guidance related to homeless populations or long-term care facilities, we are speaking with organizations that are on the ground and working with those populations so that we truly understand the experience that they're having on the ground in protecting and promoting the health of those populations. So in summary, I would say we're very interested in the intelligence that those folks have to offer, both from the qualitative side of things so that we can take that into account for our guidance, and also for the data side of things in trying to ensure that we're pulling on the wisdom of those communities and their access to those vulnerable populations in the best and most respectful way possible, directly, but also through our colleagues at StatsCan and other organizations.
Julie, anything you'd like to add?
Yes, there's a DG at StatsCan who's responsible for a very large committee mandated by PCO, who's looking at discrimination and inequalities. And they are studying race and Aboriginal status and some woman issue. And it's a collaboration with the Public Health Agency. It's a collaboration with Heritage Canada and other player, the part that used to be wage, woman and gender equity. So they are a group. I'm not part of that group, so I don't know exactly where they are in the process, but I will certainly bring to that idea that maybe doing crowdsourcing or reaching out to nonprofit or support, and they're also under their mandate, they're also the homeless. So they have a lot of those little pocket that you mentioned. I will bring to them the idea that maybe they could use something similar to crowdsourcing, but with a call to organization to gather information on how much the need for service have raised during the crisis, and any question that I know that because we hear it, that most of the charity that are delivering food to home are like, have doubled how much they have to provide during a week, but there might be a lot of other services that we don't hear about. So I'm going to bring that question back to my colleague. Thank you.
Excellent, and thanks to the person who submitted that question. Martin, anything else on your list?
Yes, please. So David, I think people are intrigued with the tool that you presented today and see it clearly as a diagnostic tool. Perhaps you could take us a little bit further in terms of how it's a prescriptive tool for policy.
Thanks. We view this tool essentially as, in part, a sort of a conversation starter for the part of looking forward in policy making. So we obviously are not experts in things like exactly how restaurants run, but you can go into the tool and take a look, for example, at that sector and look at the different occupations, fine occupations in there. When you do that, you come up with this sort of result that was a little surprising to us, at least, which was the servers themselves are obviously high risk, the people who are there going to deliver the food to you. But the highest risk category was the food service managers. And the reason really is because they're in contact with the people at the back, the cooks, who tend to be low risk by most of the measures we have, and with the people at the front and the public. And so we view that as an example of a situation where you look at this and you say, okay, we're going to talk to the food service industry. We're not going to prescribe to the food service industry what to do, but we are going to say to them, look, we can see that this is an important group. You're using masks for servers. You're maybe putting up plexiglass in places, but what are you doing for this group? And so that's the sense. We view this not as much of a tool to say you must do this or do this in this order exactly, as a way of engaging with the people who have the on the ground information and providing a consistent way to have that conversation.
Okay, thank you. And one last one, Kathleen, from my end, with about 5 minutes still to run. Right up front, Rhonda and I think Julie both referred to not only what new data are being collected under these extraordinary circumstances, but also honestly recognizing some of the key data gaps. And I guess the question broadly would be, what are the lessons learned through COVID on the data gaps and how best to fill them? And somewhat related to that, what additional questions might, for example, be included in the upcoming cycle of the CCHS, the Canadian Community Health Survey, that would be COVID related, that would then enable us to get a better finger on the pulse of how things are changing as a consequence of the COVID impacts. So that would be Rhonda and Julie, probably, in whatever order.
Or Judy, do you want me to start?
Yes.
Okay, thanks. So I think one of the biggest lessons learned for me has been that while we have done so much preparatory work for a situation in which a pandemic may arise, there's still a really good opportunity for us to be putting in place infrastructure and resources to very rapidly flip a switch, if you will, and have studies that are pre-planned and ready to go, REB approved, what have you. We continue to find ourselves a little bit behind the 8 ball, if you will, I think in Canada, and I would argue in other countries too, that when these situations come up, we're able to stand up surveillance systems pretty quick. But surveillance is not the same as research, has a very different fundamental mandate and objective. From the research side of things, there is most certainly an opportunity for us across the board to start thinking about, regardless of what the infectious disease is, we tend to have some similar questions, and we probably could be setting up ahead of time opportunities for government and the research community to be partnering, to think proactively about how best to get that infrastructure in place to very quickly launch studies. That is one of the lessons learned for me as I've been reflecting on this a lot over the last couple of weeks. So I thank you for that question. It's a really important one. Thanks.
So I have something to add. So there's when we build survey, there's a balance that we need to have between things that don't change and things that change. I will present it like that. So as opposed to economy where there are ups and downs and things move from month to month, things tend to take a long time to change in health. So we measure things in our large current surveys such as CCHS. And at some point after 8 or 10 years of measuring something that doesn't change, it's quite tempting to move and measure something new. And we've done that a lot with CCHS. We have redesigned CCHS 3 times over the last 5 years. At some point, we get rid of the module about need for health service because it was so stable that it was deemed by researcher or by whoever is paying for the data or whoever want to use the data, it was deemed like boring to ask the same 5 questions and receive the same response. So over the last year, we've implemented in our survey tool new content that is quite trendy and we hear about and people have questions, but in order to do that, sometimes we get rid of things that could be used for surveillance and are likely to be impacted when there's a crisis. But as everybody, we always think there's not going to be a crisis. So lesson learned for me is, oh my God, what have we done with the health services module? and other questions like that here and there that we've dropped from survey because they were just too stable and would be really interesting question to have a baseline to compare with now.
Mm-hmm.
That's very helpful. Thank you. Kathleen.
And I like to share that with researcher because researcher like novelty, and I'm leading an analyst group. I totally get that. I totally understand that, but the data need to be there too for surveillance reason or for policy making.
Understood. Kathleen, if I could take the liberty as we just come to the close as Executive Director of the CRDCN, not only to thank the panelists today and to thank you for your excellent job moderating today's, again, super session, as all of these have been over the last week and beyond. We started off really for this whole session of this series trying to do 3 things. Identify key questions that matter in each of the thematic areas, especially that we've been addressing over this week. What data exist or need to exist in order to address those questions? And what teams across sectors as well as within the academy do we need to bring together to best answer those questions? And it's been really helpful to hear 2 things, I think, through these sessions this week. One, the appetite. To address the questions and to come together and to push insofar as possible on the levers to get those data that would enable us to answer the questions as effectively as possible. And just the level of enthusiasm and engagement, I think, is extremely encouraging. So as we look at it from a network point of view, this is indeed encouraging that there are so many people who have not only subscribed, which is over 1,000 now, I think, well over 1,000 over this series of webinars this week and the earlier one that introduced the session. And that's indeed an encouragement for all of us in obviously what are typically very difficult times. And so that old adage of not losing the opportunity of a crisis, as serious as the crisis might be, I think has really come home with force. And I just want to thank today's panel and the ones that previously happened this week and all of those who participated to have contributed so effectively in making sure that we make real progress even through these very difficult times. And Kathleen, back to you and thank you.
Okay, so I'll just sum up by saying thank you for having me. I concur with everything Martin said. A couple of just closing notes. CRDCN is a fabulous organization, as most of you on the call will know. Please have a look at the organization's 2019 to 24 strategic plan that's on the CRDCN website. It'll just reinforce how eager the CRDCN is to serve you and engage you over the coming years. Au nom de RCCDR, je tiens à remercier David, Rhonda, Julie et Tracy, ainsi que tous les participants. Je vous encourage aussi à prendre le temps de lire, si n'est pas déjà fait, le plan stratégique du réseau, disponible en français sur le site web de RCCDR. And for everyone, there's a video recording that will be made available, again, on the CRDCN website in the days to come. Thank you all for your tremendous contribution. Merci beaucoup et bonne journée.
Thank you.
Thank you.